finish off with brain tumors. So what are cerebrovascular diseases? These are, as the name suggests, cerebral, meaning the brain or the central nervous system. Then vascular, these are disorders that affect blood vessels. So these are caused by pathologic processes involving blood vessels. And these pathological processes can include where you have thrombotic occlusion, so you form a clot inside the blood vessel, where you have embolic occlusion, so you have a clot coming from maybe the heart or the lower limbs and gets into the brain vasculature, and then it occludes a blood vessel. Or you can have these blood vessels undergoing rupture. We had a lecture on atherosclerosis, and we talked about the changes that can occur in blood vessels that are affected by atherosclerosis. That you can have ulceration of those atherosclerotic plaques that leads to the formation of clots. Also, the fact that you have atherosclerosis, this interferes with oxygenation of the blood vessel and leads to weakening of the blood vessels, so they dilate to form aneurysms, and these aneurysms eventually will rupture. But we'll see also other mechanisms that can lead to this thrombotic occlusion and vascular rupture. So these cerebrovascular diseases are what is referred to as a stroke. So when someone has a stroke, either they had a clot in one of the blood vessels in the brain, or that formed within that blood vessel, or you have a clot coming from another part of the body, or you have blood vessels within the brain that have ruptured. So a stroke or a cerebrovascular accident is an acute compromise of the cerebral perfusion or vasculature. So approximately 85% of the strokes are usually ischemic. So you have blockage of the blood vessels, and the rest are hemorrhagic, where you have a rupture of a blood vessel, and then you have bleeding. But majority of the strokes are usually ischemic. So hemorrhage usually accompanies rupture of vessels and leads to direct tissue damage as well as secondary ischemic injury, because when a vessel ruptures, it means that downstream from that rupture, there's not going to be any blood supply, and therefore you're still going to get some ischemia. We know that the brain is a highly oxygen-dependent tissue that requires a continual supply of glucose and oxygen from the blood. So these pathologies will result in loss of oxygen and metabolic substrates to the brain. And this can also occur in systemic illnesses. So you can get ischemia when you have, for example, hypovolemic shock, which we went through last year. So when you have reduced blood flow to the brain, then this is still going to cause some form of loss of oxygen. Also, when you have hypoglycemia, which is an important substrate for metabolic activities. So stroke is the leading cause of adult disability worldwide. So apart from trauma, most people who are paraplegic or quadriplegic most likely had a cerebrovascular accident. It is therefore critical to recognize strokes early and treat it rapidly to prevent or minimize morbidity and mortality, to try and prevent those permanent disabilities that can lead someone maybe never to walk again. Hypertension is the leading cause of ischemic stroke. So most people who have cerebrovascular accident, if you examine their history, most of them have a history of hypertension. Other risk factors for cerebrovascular diseases are your diabetes, smoking, obesity, atrial fibrillation, and drug use. Why is atrial fibrillation? Because atrial fibrillation usually creates stasis, and you end up having a clot formation within the heart chambers, and then these clots are the ones that will be dislodged to the central nervous system and cause that embolic occlusion of a blood vessel. Also, drug use, they usually can cause spasms of blood vessels within the brain, and you have occlusion, and you end up having a cerebrovascular accident. So in the younger population, there are numerous causes of stroke, including, for example, those who have clotting disorders. We went through thrombosis, and you learned that you can have inherited hypercoagulable states, like, for example, those with protein C deficiency, those with protein S deficiency, those with factor 5 Leiden. So clotting disorders can cause you to form clots easily, and one of the places where you're going to form clots is in the brain. They can also develop carotid dissection, and also in younger population, illicit drug use is a very important risk factor. So hemorrhagic infarcts occur due to hypertension, where you have an aneurysm rupture in patients who have anterior venous malformations. We'll see what these are. Venous angiomas, and bleeding can also occur due to illicit drugs like cocaine. So cocaine, they lead to changes in blood pressure, and this can lead to rupture of blood vessels. So patients with cerebrovascular diseases, how do they present? So they're going to present with decreased level of consciousness. Some of these are usually abrupt to the extent that people just fall into a coma. In clinical practice, we use what is called a Glasgow coma scale, and you're able to determine the level of decreased consciousness in this patient. So you can have someone who's talking to you 1 minute, the next minute they are not responding. Other ways is they start to develop slurred speech. Also, they can have motor deficits, like they are unable to move one side of the body. They can have visual field deficits, they're not able to see like they were seeing before. They can have also eye movement abnormalities. You learned about cranial nerves and those like abducens nerve, which is important for muscle movement in the eye. They can have facial paralysis if the stroke is affecting where the seventh cranial nerve is. And they can also have ataxia, where they have this uncoordinated gait. So it's important to know we are talking about thrombotic occlusion or rupture. We're talking about hemorrhage, ischemia. It's important to know what these terms mean. So we have hypoxia, ischemia, and infarction, which are very important when you're talking about cerebrovascular diseases. So hypoxia is a condition in which the body or a region of the body is deprived of adequate oxygen supply at the tissue level. And we've said there are many things that can cause hypoxia. For example, if you have pneumonia, and we know oxygen carbon dioxide exchange occurs within the lungs, and you have respiratory failure and you're not able to have that proper oxygen carbon dioxide exchange, then your blood doesn't have enough oxygen. So it will lead to hypoxia, which is a condition in which the body or a region of the body is deprived of adequate oxygen supply, even in patients who have anemia, for example. And hypoxia can also result from your obstruction of your blood vessels, so that the area that is distal to that obstruction, it's not receiving blood. And blood, of course, comes with it oxygen. So it will lead to oxygen deprivation. Ischemia is a restriction in blood supply to tissues, causing a shortage of oxygen that is needed for cellular metabolism. So ischemia is one of the causes of hypoxia. Infarction, on the other hand, refers to tissue death caused by occlusion of vascular supply to the affected tissues. And we covered all this in the previous semester. So let's look at some of the conditions. We'll start with global cerebral ischemia. And global means that it is affecting the entire brain, the term global. So this usually results from severe systemic hypotension when systolic pressures are less than 50 millimeters of mercury. And this can occur in patients who have cardiac arrest or what we call cardiogenic shock. So of course, there's no blood pressure, the blood pressure plummets, and the brain is not able to receive adequate blood supply, and this is going to lead to global cerebral ischemia. The clinical outcome will vary with the severity and duration of the insult. So, of course, if it's that cardiac arrest occurs and you're able to revert it in less than maybe a minute or two, then of course the severity of this global cerebral ischemia is going to be reduced, because once you restore blood supply, then the brain gets enough oxygen. And we know that the brain, it takes about 4 minutes for your neurons to die. But if that duration now is prolonged, then of course the changes are going to be more severe. So when the insult is mild, there may be only a transient post-ischemic confusional state with eventual complete recovery. We know that I've said that neurons are more susceptible to hypoxic injury than are glial cells, and therefore they are the most susceptible to when you have loss of oxygen supply. The most susceptible neurons in the brain are usually your pyramidal cells in the hippocampus and the neocortex, and also the Purkinje cells in the cerebellum. I hope you remember this from your anatomy. So in severe insults, patients who survive often remain severely impaired neurologically and in a persistent vegetative state, because their neurons have died and therefore their brain function is no longer existent. So brain death can also occur in which all voluntary and reflex brain and brainstem functions are absent. In global cerebral ischemia, the brain is usually swollen with wide gyri and narrowed sulci. Of course, where you have carbon dioxide, you have reduced metabolic activity, accumulation of lactic acid. What do all these do? They attract water into the brain, leading to swelling, and then you end up having features of increased intracranial pressure, which are your wide gyri and your narrowed sulci. So the cut surface usually shows poor demarcation between the gray matter and the white matter. So if you can have global cerebral ischemia, you can also have focal cerebral ischemia, which means that only a part of the brain is affected. So when you have cerebral arterial occlusion, this leads first to focal ischemia and then to infarction in the distribution of the compromised vessel. And we say that in the brain, the type of infarction and necrosis that you get is liquefactive necrosis. So the size, location, and shape of the infarct and the extent of tissue damage will depend on collateral blood flow. And we've talked about this. So is there an alternative blood vessel so that if one is occluded, there's another one that is supplying that part of the brain. So collateral flow through the circle of Willis or cortical leptomeningeal anastomosis can limit damage in some regions. For the thalamus, the basal ganglia, and the deep white matter, these have little collateral blood flow, and therefore when you have any blockage of blood vessels that supply these regions will be prone to permanent damage. So what will cause you to have an infarct? We've talked about emboli. So you have another clot coming from another region of the body to the brain vasculature. And this is seen in patients who have cardiac neurothrombi, those who have valvular disease. We've talked about atrial fibrillation, those who have thromboemboli from atheromatous plaques in the carotid arteries or in the aortic arc, patients with deep venous thrombosis or fat emboli that comes in patients who have fractures of the long bones. And the territory of the middle cerebral artery is usually the most susceptible to emboli. Then you can have infarcts that are caused by thrombotic occlusions. These are usually superimposed on atheromatous plaque. On our lecture on atherosclerosis, where we were talking about in the descending order of the blood vessel areas that are mostly affected by atherosclerosis. We talked about the sac of Willis being one of the vasculatures that are susceptible to atherosclerosis. So therefore, you can see that thrombotic occlusions do occur in the brain. And this is because of maybe you have an ulceration of the atheromatous plaque and then you end up forming a clot. So common sites are the carotid bifurcation, the origin of the middle cerebral artery, and either ends of the basilar artery. So go back to your anatomy of the brain so that you can recap on the blood supply of the brain. You can have so the infarcts that result, you can have what are called lunar infarcts or hemorrhagic infarcts. So lunar infarcts, these are small infarcts of only a few millimeters in diameter. You also have hemorrhagic infarcts, which usually manifests as multiple or confluent petechiae hemorrhages. Another cerebrovascular disease is you can have bleeding within the brain, what we call intracranial hemorrhage. And hemorrhages within the brain are caused by, you can have hypertension and other diseases leading to vascular wall injury. You can have structural lesions such as arteriovenous or cavernous malformations. We will see this. Or you can have tumors within the brain that lead to vascular rupture. Remember, we've said at the beginning, the pathological processes that lead to cerebrovascular injury is thrombosis, embolism, or vascular rupture. So in intracranial hemorrhage, it usually will result from intracranial rupture, vascular rupture caused by hypertension or vascular wall disease, structural lesions of blood vessels, and tumors. And we know, of course, tumors, when they invade blood vessels, it can cause blood vessels to rupture. So subarachnoid hemorrhage, most commonly, hemorrhages most commonly are the result of ruptured aneurysms, but also occur with other vascular malformations. Rarely is intracranial hemorrhage in the form of subdural or epidural hemorrhage as a result of these diseases, hypertension and also vascular disease. Majority of your subdural and epidural hemorrhages are usually associated with trauma, unless now you have diseases, vascular diseases that affect the blood vessels within your dura. So spontaneous, that is non-traumatic intraparenchymal hemorrhages are mostly due to rupture of a small intraparenchymal blood vessel. Hypertension is a leading cause, and hemorrhages mainly occur in the basal ganglia, the thalamus, the pons, and the cerebellum. Intracerebral hemorrhage can be clinically devastating when it affects large portions of the brain, or it extends into the ventricular system, so that you have an intraventricular hemorrhage. So these hemorrhages can be clinically silent when they're small, or they can be significant when the areas that are affected are extensive. The location and the size of the bleed will determine its clinical manifestation. So that if you have, let's say, a bleed occurring in the Wernicke or Broca's area, of course, speech is going to be affected. If you have one occurring near the optic chiasma, then of course vision is going to be affected. So the location and the size of the bleed is going to determine its clinical manifestation. So resolution of the hematoma results in considerable clinical improvement. So you want to identify and constitute the appropriate management almost immediately. In acute intracerebral hemorrhage, the extravasated blood compresses the adjacent parenchyma, and depending on which brain parenchyma is affected, then you'll have clinical features that suggest which part of the brain has been affected. So this is just an image to show you an intracerebral bleed, and this has extended into the ventricles. So you have a bleed within the brain parenchyma that has extended into the ventricle. So we've said hypertension is one of the risk factors for cerebrovascular disease. So let's see how hypertension actually causes cerebrovascular disease, that is hypertensive cerebrovascular disease. So hypertension usually causes hyaline arteriolar sclerosis, which we went through at the beginning of this semester. And it causes that hyaline arteriolar sclerosis of the deep penetrating arteries and arterioles that supply the basal ganglia, the hemispheric white matter, and the brainstem. So the affected arteriolar walls are therefore weakened and they become more vulnerable to rupture. This hypertensive implications of this causing this hyaline arteriolar sclerosis with weakening of blood vessels can also lead to dilatation of these blood vessels. So you get minute aneurysms. These are called the Charcot Bouchard microaneurysms that may also form in vessels less than 300 micrometers in diameter. So they can cause dilatation of the blood vessels. So you can have, so as a result of hypertension, you have hyaline arteriolar sclerosis that leads to weakening of your blood vessels, and you can also develop minute aneurysms called the Charcot Bouchard microaneurysms. And now this will lead to infarction. So you form the lacuna infarcts. So these are small infarcts, a few millimeters in size, commonly found in the deep gray matter of the basal ganglia and thalamus, the internal capsule, the deep white matter, and the pons. And they are caused by occlusion of a single penetrating branch of the large cerebral artery. And depending on the location, the lacunae may be silent clinically or cause significant neurologic impairments. You also have a rupture of small caliber penetrating vessels, and this leads to the development of small hemorrhages. And these hemorrhages, of course, will be resorbed, leaving behind a slit-like cavity, what we call slit hemorrhages, surrounded by brownish discoloration. Of course, when you digest hemoglobin, one of the color changes that you expect in that process is brown. So in hypertensive cerebrovascular disease, it can either be acute or chronic. So you can have acute hypertensive encephalopathy, and this is usually associated with sudden, sustained increases in diastolic blood pressure. When you have a diastolic blood pressure greater than 130 millimeters of mercury, you're likely to develop acute hypertensive encephalopathy. And that's when you learned in hypertension that there's something called malignant hypertension. And this is usually a medical emergency because of the end of organ damage that it can cause. And one of the things that it can cause is your acute hypertensive encephalopathy. So this is usually characterized by increased intracranial pressure and global cerebral dysfunction. and this will manifest as headaches, confusion, vomiting, convulsions, and sometimes this patient will present with coma. So rapid therapeutic intervention to reduce blood pressure is usually essential in such cases. If the patient dies, post-mortem examination may show brain edema with or without transtentorial or tonsillar herniation because, of course, of the changes that occur within the brain. Petechiae and fibrinoid necrosis of arterioles in the gray matter and white matter may also be seen microscopically in patients with acute hypertensive encephalopathy. We say that you can form subarachnoid hemorrhages. So this refers to bleeding into the subarachnoid space. And the causes of this is when you have rupture of circular what are called berry aneurysms. These are thin-walled outputtings of an artery. And this is usually the most common cause of subarachnoid hemorrhages. Or you can have vascular malformations, you can have trauma, you can have coagulopathies, or you can have tumors that lead to rupture of blood vessels that are located in the subarachnoid space, giving you subarachnoid hemorrhages. So this is just an image to show you. Of course, you know the meninges. The outermost is your dura, then you have your arachnoid matter, and then you have pia mater, which is usually now attached to the surface of the brain. So between the pia mater and the arachnoid matter is where you find your subarachnoid space, the area below the arachnoid matter. So when you talk about a subarachnoid hemorrhage, you're talking about hemorrhage that occurs in the subarachnoid space. So patients with a subarachnoid hemorrhage get a sudden excruciating headache, and then they rapidly lose consciousness. In the early period after a subarachnoid hemorrhage, there's usually an additional risk for ischemic injury from vasospasms of other vessels. So healing and the attendant meningeal fibrosis and scarring sometimes will obstruct CSF flow and disrupt CSF resorption, leading to hydrocephalus. So one of the side effects of having a subarachnoid hemorrhage is that they will heal with fibrosis. Of course, you know the arachnoid matter is a part of the meninges. So when you have a hemorrhage, you affect oxygen supply to these meninges, and of course, some of the tissues will die and heal with fibrosis. And this is where CSF flows. You can see in this image, the CSF is coming from your ventricles and it's flowing between the subarachnoid space. So therefore, if you're healing with fibrosis, then that flow of CSF is affected, and these patients are going to get hydrocephalus is one of them effects. We've said this subarachnoid hemorrhage can be caused by circular aneurysms, and we say that this is the most common. So the aneurysms are usually not present at birth, but develop over time because of underlying defects in the vessel medium. The risk factors for developing circular aneurysms are, for example, those with autosomal dominant polycystic kidney disease, or those who have genetic disorders of extracellular matrix proteins, like those with Ehlers-Danlos syndrome. In about 1/3 of the cases, rupture of a circular aneurysm occurs at a time of an acute increase in intracranial pressure. For example, when you're straining as you're passing stool or during a sexual orgasm. So in 20 to 30% of the cases, a patient may have multiple aneurysms, and the probability of an aneurysm rupturing will increase with age and the size of the aneurysm. So this is just to show you the circle of Willis and to show you the various areas where the circular aneurysms occur. And at the area of the anterior communicating artery, you have 40% of the circular aneurysms forming in this area. We've also called them perianeurysms. Then at the region of the middle cerebral artery, you're going to have about 20%. At the bifurcation of the basilar artery to form your posterior cerebral artery, you're going to get about 4% of your circular aneurysms forming. So this is just an image. I think this patient had an angiogram, and this to show you the dilatation. I think this is the region of the anterior cerebral artery, and you can see this aneurysm forming. We said that this subarachnoid hemorrhages can also occur due to vascular malformations. And these vascular malformations include your atriovenous malformations, what we call AVMs, cavernous malformations, capillary telangiectasia, and venous angiomas. So what are AVMs? So these are the most common vascular malformations. These are abnormal fistulas between arteries and veins without an intervening capillary bed. Of course, we know that for arterioles, as they're supplying tissue, they reach towards the end. They have capillaries that allow for that passage of oxygen and nutrients to the tissue. And then they have a venular end where now the fluid goes back into circulation and then into the veins and supplied back to the heart. So for arteriovenous malformations, you just have abnormal communications between the arteries and veins, and you don't have an intervening capillary bed. So high arterial flow directly into the venous structures can lead to disruption of the venous walls and ultimately cause fetal hemorrhages. So you're subjecting the venous circulation to the high pressures in the arterial circulation. So AVMs affects mostly males, and they will manifest between 10 to 30 years of age. And these patients are going to manifest with seizures, and then they're going to have an intracerebral hemorrhage, most likely a subarachnoid hemorrhage. It is the most dangerous type of vascular malformation because the vessels are unstable and they can easily rupture. Where you have multiple AVMs, this can be seen in the setting of hereditary hemorrhagic telangiectasia, which is an autosomal dominant condition often associated with mutations affecting the transforming growth factor beta pathway. So these AVMs may involve the subarachnoid vessels extending into the brain parenchyma, or those that occur exclusively within the brain. And on gross inspection, they usually resemble a tangled network of worm-like vascular channels, like you can see here. So you have this tangled network. They look like worms, and it's a mixture of both arteries and veins. And then now they can easily rupture and give you a subarachnoid hemorrhage. Then we have cavernous malformations. These are lesions that consist of dilated endothelial channels or caverns that lack smooth muscle support and are filled with blood or thrombus. We went through the structure of blood vessels. Of course, we said the inner lining, you have your endothelium, and then the media usually has your smooth muscle. So for cavernous malformation, you just end up having endothelial channels. You have just the endothelial lining, and you lack the smooth muscle support. And then these contain blood, and they can also have clots. There's usually no intervening nervous tissue in this cavernous malformation. They occur most often in the cerebellum, the pons, and the subcortical regions. Occasionally, they will rupture, leading to hemorrhagic stroke, and they can also cause death, as you can see here. They are dilated. You can see even with the structure, you can see they are thin, not the normal blood vessel structure. The other type of malformation is your capillary telangiectasia, and these are microscopic foci of dilated thin-walled vascular channels that are separated by relatively normal brain parenchyma. They occur most frequently in the pons, and most of the time they're usually asymptomatic. Another malformation that you can have is your venous angiomas, what we call varices, which consist of aggregates of ectatic venous channels, but this usually will rarely bleed. So we said you have these thin channels, and then they're separated by relatively normal brain tissue. So this is capillary telangiectasia. And then this is your venous angiomas. You can see these dilated, thin-walled blood vessels within the brain. Another cerebrovascular disease is your cerebral amyloid angiopathy. And this is a disease in which you have amyloidogenic peptides that deposit in the walls of medium and small caliber meningeal and cortical vessels. You have amyloid deposition that weakens your vessel walls and increases the risk of hemorrhage. So this cerebral amyloid angiopathy is usually associated with hemorrhages that will often occur in the lobes of the cerebral cortex, giving you lobar hemorrhages, but it can also result in the small cortical hemorrhages that are less than a millimeter in diameter, what we call micro hemorrhages. And of course, amyloid is usually seen in some of the lymphoproliferative neoplasms. Another cause of subarachnoid hemorrhage, we said, is vasculitis, and these are inflammatory processes involving blood vessels. So when it The brain has several cells, and these have different functions. So we have the neurons. Of course, the neurons are important in signal transmission, and also, that involves processing of sensory and motor for you to talk, for you to move your eyes. So that signal transmission. Then we have supportive cells, and these are called your glial cells. So there's the neurons and then the glial cells that support the neurons. So the glial cells consist of your astrocytes. So these support neurons, and they help to maintain the blood-brain barrier, and they repair CNS injury when it occurs. Then we have oligodendrocytes. These are cells that myelinate your CNS axons. Please go back to your anatomy, physiology, you recap on myelination. Then we have ependymal cells. These are cells that line ventricles and the central canal, and they usually produce CSF. Then we have microglial cells. These are CNS macrophages, and these are usually important for immune surveillance within the brain. So when you have brain tumors, they can affect any of these cells. So, so these CNS tumors are usually classified based on the cell of origin, and the WHO histologic grading. We're going to look at the WHO histologic grading. So you can have astrocytic tumors. These are tumors that result from astrocytes. These are the most common, and you have what are called astrocytomas, and the malignant version, the glioblastoma. Then you can have your oligodendroglial tumors. These arise from your oligodendrocytes. An example of this is your oligodendroglioma. Then we have ependymal tumors, which arise from your ependymal cells. An example here is your ependymoma. Then you can have tumors arising from your neurons or both your neurons and glial cells. So you can have neuronal tumors or mixed neuronal glial tumors. So you can have a ganglioglioma, which is a mixed neuronal glial tumor, or you can have a neurocytoma, which is purely a neuronal tumor. Then you also have embryonal and primitive tumors. An example here is your primitive neuroectodermal tumors. These are tumors that are arising from primitive tissue in there. Remember, the brain comes from what? You have your mesoderm, ectoderm, endoderm. So those that are coming from those primitive tissues, we call them embryonal primitive tumors. The most common is your medulloblastoma, which we will discuss. Then we have meningeal tumors, of course, the meninges. The dura, we've just looked at it right now. The dura, the arachnoid mater, the pia, you can have tumors that arise from the meninges, and we call them meningiomas. Then you can have primary CNS lymphomas, and you can also have metastatic tumors. These are coming from systemic tumors that metastasize to the brain. So it will depend on your cell of origin. When it comes to epidemiology of brain tumors, primary CNS tumors. So these are tumors now that arise from the cells of the CNS, your astrocytes, your ependymomas. These are less common than metastatic. So when you find a patient with brain tumors, most likely they're having a metastatic tumor to the brain as opposed to a primary CNS tumor. In terms of age distribution of these CNS tumors, in children, CNS tumors are the most common solid tumors. So in children, brain tumors are common. In adults, CNS tumors are less common. And when they occur, those that arise from glial tissues are usually predominant. Brain tumors affect about 20 people per 100,000 population per year, and this will vary depending on regions. This is usually also affected by diagnostic modalities that makes some of these cases more reported in certain areas as opposed to others. The most common primary CNS tumors are your gliomas. particularly your astrocytoma. So this is the most common brain tumor. And then we say that metastatic tumors are the most common CNS tumor overall in adults. And of course, the primary culprits are usually your lung cancer, your breast cancer, your kidney cancer, melanomas, and colon cancer that mainly metastasize to the brain. In terms of frequency, for your primary CNS tumors, which we said affect mainly in adults, the main histologic types are your astrocytoma and your gliomas, and this will affect 40 to 50% of the cases. So 40 to 50% of primary brain tumors in the adults are going to be astrocytomas or gliomas. Then 20% will be meningiomas. Those that affect the meninges. We have pituitary adenomas that account for about 10%. And then the other histologic types, your ependymoma, your oligodendroglioma, your lymphomas, make up less than 10%. For children, their primary CNS tumors, 35 to 40% are going to be astrocytomas, and then 20% are medulloblastomas, 10% are ependymomas, and then 10 to 15% are the other histological types. But in both adults and children, you can see that the commonest primary CNS tumor is your astrocytoma. For your metastatic tumors, this represent 20 to 50% of all CNS tumors in adults. And in terms of primaries that mainly metastasize to the brain, we have the lung, which constitutes about 40 to 50% of the metastases. So the commonest metastatic tumor to the brain is lung cancer, followed by breast, constitutes about 15 to 20% of the metastases. Kidney cancer gives you 10%, melanomas 5 to 10%, and colonic cancers that gives you about 5%. So what predisposes you to get brain cancer? So there are certain risk factors. So there are genetic or familial syndromes that predispose you to having brain cancer. So for example, those with Lee-Fraumeni syndrome, these are patients with mutations in the P53 gene. So they are likely to have astrocytomas and glioblastomas. Then we have those with Charcot syndrome. This is a syndrome associated with mutations in your APC gene, and these patients are likely to have medulloblastomas and also gliomas. And then we have NF1 and NF2 gene that gives you your hereditary neurofibromatosis, and these are patients who are likely to get gliomas, schwannomas, and meningiomas. Apart from these genetic familial syndromes, you also have environmental conditions. For example, those receiving ionizing radiation, that exposure increases the risk of developing brain tumors. In patients with immunosuppression, particularly those with HIV and AIDS, are likely to develop primary CNS lymphoma. In fact, majority, I've never seen a primary CNS lymphoma in a patient other than those who have HIV. So that HIV increases the risk. Also, immunosuppression caused by transplantation can also predispose you to primary CNS lymphomas. Then in terms of gender, so there are certain tumors that are common in certain genders. For example, meningiomas are more common in females. And for gliomas, they are slightly male predominant. Your astrocytomas, your glioblastomas, you're likely to see them in males as opposed to females. Currently, we grade CNS tumors, and what we use is the WHO grading system that usually grades CNS tumors from grade 1 to 4. And this grading is usually based on morphology or what you see on histology. So the cell type. Is there atypia? You went through this in general pathology, the features of malignancy, pleomorphism, hyperchromasia, variation in shapes and sizes, increased nuclear cytoplasmic ratio, all this is atypia. Then mitotic figures, of course, with tumor, there's increased mitotic activity. Is there necrosis? Is there vascular proliferation? So all this will determine the type of grade the tumor is going to have. So that if you have a tumor with marked atypia, increased mitotic activity, marked necrosis, and vascular proliferation, this is a tumor that is going to be given a WHO grade, grade 4. Then this grading system also looks at the growth pattern. Is this tumor well circumscribed or is it infiltrative? So, of course, an infiltrative tumor cannot be grade 1. A circumscribed tumor is usually grade 1. For example, your meningiomas are usually well circumscribed. Then now we've introduced molecular markers. So molecular markers will determine the grade. So you can find a tumor that may not be the features may not, like the atypia may not be as marked, but the fact that it has certain molecular markers makes that tumor a poor prognostic tumor, and therefore it will be given a WHO grade of 4. So currently we are also including molecular markers. Of course, we don't employ that in this country because of our resource settings are we have a low resource setting, but in the West you cannot report a brain tumor without giving the presence or absence of certain molecular markers. Some of the molecular markers that are of interest when you grade CNS tumors, for example, your IDH, isocitrate dehydrogenase mutation that is usually commonly seen in astrocytomas. I'll discuss it a bit. Deletions, like deletions in the short arm of chromosome 1 and the long arm of chromosome 19. So that co-deletion is diagnostic of oligodendrogliomas. So histologically, you can see a tumor resembling an astrocytoma, but the fact that you've done molecular markers and you see the IP19Q co-deletion, that tumor automatically becomes oligodendroglioma as opposed to an astrocytoma. Then the other molecular markers like ATRX, TP53, H3K27M, which we will discuss and see the importance in various brain tumors. So for your WHO grade 1 tumors, these tumors are usually slow growing. They are often circumscribed. They're usually curable by surgical excision, and rarely will they recur if completely excised. So once you remove them, they are unlikely to recur. As examples of grade 1 tumors are your example pilocystic astrocytoma, your subependymomas, and your gangliogliomas. Histologically, these tumors usually have a low cellularity, they have minimal atypia, they have rare or absent mitosis, they have no necrosis, they have no vascular proliferation, and most of the time these tumors are seen in children, and they usually have an excellent prognosis. For your WHO grade 2 tumors, their characteristics include that they're usually not well circumscribed, so they'll have an infiltrative growth. They have a higher recurrence risks that when you resect them, they're likely to come back. Then they can progress to higher grades. So they can move from grade 2 to grade 3 to grade 4. So they undergo malignant transformation. An example of a WHO grade 2 tumors are, for example, your diffuse astrocytoma that is IDH mutant. So you've done your molecular markers and you found that they have mutations in your IDH gene. Or you have your oligodendrogliomas that you've proved they have the IP19Q co-deletion. Or your low-grade ependymomas, these are WHO grade 2 tumors. Histologically, they usually have mild to moderate cellular atypia. They also have rare mitotic figures, and of note, you should not see necrosis and you should not see microvascular proliferation. Clinically, these tumors are usually slow growing. but recurrence and progression is usually common. And when you diagnose a patient with a WHO grade 2 tumors, they require long-term monitoring, because of if you excise them, the recurrence risk we've said is high, and also the fact that these tumors can also progress into grade 3 or grade 4 tumors. Then we have the WHO grade 3 tumors. These are usually malignant with aggressive behavior. They have high risk of recurrence, and they often require not only surgery, they require radiotherapy, and they also require chemotherapy. An example of a WHO grade 3 tumor are your anaplastic astrocytoma, and you can see the name starts with anaplastic, so there's increased anaplasia, anaplastic oligodendroglioma, anaplastic ependymoma. So for your astrocytoma, your oligodendroglioma, ependymomas, they can range from grade 1 all the way to grade 4, depending on the histologic features. So the histologic features in grade 3 tumors, they usually have increased cellularity, they have marked nuclear atypia, they have frequent mitosis, they may have microvascular proliferation, but what differentiates them from grade 4 tumors is that there is no necrosis. Of course, the implications is the prognosis will be dependent on the tumor, and then they usually have a median survival that is shorter than grade 2 tumors. For your grade 4 tumors, they are very aggressive, they have rapid growth rate, they have a poor prognosis, and they require multimodal therapy, surgery, radiotherapy, and chemotherapy. So examples of your grade 4 tumors are your glioblastoma, your medalloblastoma, which is your primitive tumor. This is usually seen in children, and your primary CNS lymphoma. This is usually a high-grade lymphoma. When you look at it histologically, high cellularity, marked nuclear atypia, frequent mitosis, necrosis is there, and they also have microvascular proliferation. Unfortunately, these tumors have a short survival, usually months to a few years, despite treatment. And even when you excise them, they come back. And these patients, once diagnosed, usually have a few months to a few years to live, if they make it to a few years. We've talked about molecular markers. So we've talked about isocitrate dehydrogenase, IDH. So you want to establish whether there's that mutation or not. And this is mainly seen in your diffuse astrocytoma or your oligodendroglioma. And the prognostic implication is that they have a better survival. And the good thing why you want to establish this is because they will be chemotherapy sensitive. So there are certain chemotherapy regimens that oncologists use, and they want to establish, is this tumor IDH, does it have a mutation or not? Then the IP19, the 1p19q code deletion, which we said is characteristic for your oligodendrogliomas. It also confers better prognosis, and its therapeutic implication is that it will show, these tumors will show PCV chemo response that is good, as opposed to those that do not have this code deletion. Then we talked about ATRX loss, which is usually seen in astrocytomas. This usually is a marker that confirms lineage together with your H3K27M. This is a marker that also is seen in midline gliomas. It has no therapeutic implication, but if you have that mutation, then it shows that you have a poor prognosis. We have your MGMT methylations that's seen in glioblastomas. It means that these tumors are going to show better sensitivity to the drug temozolomide. Then we have your BRAF mutations, which are commonly seen in pilocystic astrocytomas and gangliogliomas. Of course, these tumors are usually often slow growing, and you will treat them by giving them BRAF inhibitors. Then we have mic amplification, usually seen in medalloblastoma. Once you see that mic amplification, shows that the medalloblastoma is of poor prognosis, and then you have to use certain therapies. So those molecular markers are good for determining therapeutic response, and they're also good for confirming lineage in some cases, and also for prognosis. So when you have certain markers, they either show that you have a poor prognosis or you have a good prognosis. How do you diagnose brain tumors? Mainly clinical features, how these patients are going to present. These are space-occupying lesions within the brain, and depending on which part of the brain is affected, the patients are going to present with features of that area that is affected. So these patients are going to present with headache, they're going to present with seizures, they're going to present with focal neurological deficits, and they're also going to present with features of increased intracranial pressure. These are usually diagnosed mainly by MRI. You can diagnose them by CT scan, but MRI will give you a better definition of the tumor that the patient has. And of course, for definitive diagnosis, the patient has to undergo surgery, you get a biopsy, and then histology and molecular markers will confirm the tumor and then give you all the other information that I've stated. For your high-grade gliomas, and also for your metastasis, this will typically, the symptoms will typically progress over days to weeks, where symptoms of your low-grade gliomas and other indolent tumors may progress over months to years. Of course, headache, we've said, is a common manifestation of brain tumors in up to 50% of the patient. In fact, if a patient goes to hospital multiple times with headache, you want to get a CT scan or an MRI just to make sure that this patient does not have a tumor. Seizures are seen in 50 to 80% of the patients. We've talked about focal deficits, which will vary based on the tumor location. So symptoms may be caused by local tissue disruption, a mass effect on nearby structures, or vasogenic edema. So the main deficits, you can have motor deficits, so they present with muscle weakness. You can have sensory deficits, so they have, like, when they have cortical sensory deficits, they have abnormalities writing, they have abnormalities talking. They might also present with visual defects. They can also present with cranial nerves deficits. Like, for example, we've said if it affects the facial nerve, they're going to have paralysis on their face. So depending on the nerve that is affected, then you're going to see effects based on that. Then these patients also present with cognitive dysfunction. So they will have memory problems. Some of them, they will be identified as having a brain tumor because of the mood and personality changes that occur, especially those with frontal lobe tumors, where mood and personality control is encompassed. So when you have frontal lobe tumors, then these patients are going to have mood and personality changes. Then they'll have features of raised intracranial pressure, where you have long-standing headache. These patients have nausea, and they also present with vomiting. They can also have symptoms due to altered hormonal levels. Let's say for a patient with a pituitary adenoma, of course, you know, all the hormones produced by the pituitary, prolactin, growth hormone, ACTH, FSH, LH, all these hormones will be affected if you have a pituitary adenoma. And we're going to discuss endocrine pathology on Thursday, and we'll understand the implications of a pituitary adenoma. So let's look at these tumors. I'll only discuss the ones that are important. For your astrocytoma, we said that this is the commonest tumor in both children and adults. This is the most common primary CNS tumor. Of course, we said it's derived from your astrocytes. Astrocytomas are commonly found in the cerebral hemispheres in adults, and in children, you're going to find it in the cerebellum. And we said that the grades of astrocytoma range from grade 1 to grade 4. So for grade 1 is your pilocystic astrocytoma. These are well circumscribed and benign tumors commonly found in children. Grade 2, we have your diffuse astrocytoma, which is infiltrative but still slow growing. Grade 3, you have your anaplastic astrocytoma. This is malignant, has increased mitosis, but has no necrosis. Then grade 4, you have your glioblastoma, which is characterized by necrosis, microvascular a proliferation marked atypia, and increased mitotic activity. Histologically, these tumors usually have a fibrillarly background, and then of course they stain for brain cells. They're going to be GFAP positive. For your diffuse astrocytoma, we said grossly they appear as poorly defined gray infiltrative tumors that expand and distort involved brain. They usually range from a few centimeters to lesions that replace nearly the entire brain. So they can be that infiltrative. So cut surface of the tumor may be either firm or soft and gelatinous. You can see cystic degeneration in some of the tumors, and the tumor may appear well demarcated, but it more commonly will be ill-defined due to infiltration beyond the perceived margins. And even on histology, you would not be able to confirm that the margins are clear from the tumor. Microscopically, the tumor is usually hypercellular compared to normal white matter. And the features that you will see enlarged, elongated, or irregular hyperchromatic nuclei that are embedded within a fibrillar background. They're usually, you can do immunohistochemistry. They're GFAP immunoreactive. So if you want to confirm that a tumor is of brain origin, we use GFAP. Excuse me. So GFAP usually stands for gliofibrillary acidic protein, and this is usually seen especially in astrocytes. So you want to confirm that the tumor is of astrocytic origin. Then also you want to do your IDH1. So an immunostain for your IDH1, your isocitrate dehydrogenase. This will highlight the tumor cells in up to 90% of the cases. We said that your diffuse astrocytoma is usually IDH1 mutant. For your anaplastic astrocytoma, which is your WHO grade 3, these have a similar appearance but are more densely cellular, and then they have readily detectable mitotic activity. And then we also talked about vascular proliferation that will be seen in your anaplastic astrocytoma. Like you can see here in the brain, you can only tell that there's a poor demarcation between the gray and white matter, but you can barely appreciate where the tumor is because it is diffuse, it is infiltrative. And then now when you take a section from there, you're going to see these cells. You can see these are larger than the usual neurons. And then this is the fibrillar background, like you see fibrils. And this is what is characteristic of your diffuse astrocytoma. You see, how do you describe fibrillar? I'm trying to find the best way to describe it for you. Like the way you see cotton wool, the way it appears, it has like multiple small strands. That's the fibrillar background. And then now you see your astrocytic cells. This was just an image to demonstrate for you the anaplastic astrocytoma. You can see these cells, yes, they're hyperchromatic, but they're still a bit regular, yeah. But once you get now to anaplasia, you can see a variation in the shapes and sizes to the extent that you can even see these a multinucleated giant cell. You can see these large cells with varying shapes and sizes. And this is the anaplasia that we are talking about. So when you see this is diffuse astrocytoma. When you see this and then you start seeing blood vessels, increased mitotic activity, then that is diagnostic of your anaplastic astrocytoma. If you start seeing necrosis, then now that moves to your glioblastoma. Then we talked about your polycystic astrocytoma, which is your WHO grade 1. This is usually localized astrocytoma. And unlike your infiltrative astrocytoma, it has discrete borders, and we say that it is commonly found in children and young adults, and it will usually be located in the cerebellum. It can also occur in regions around the third ventricle, the optic nerves, the spinal cord, and occasionally you can see a polycystic astrocytoma in the cerebral hemispheres. Molecularly, they have a distinct genetic alteration of the MAP kinase pathway, and the most common being that BRAF gene fusion. So when you have histologically a tumor that appears to be a polycystic astrocytoma, you want to look for the BRAF gene mutation because we said it has, you will give them BRAF inhibitors. And we say that these tumors are slow growing and can often be treated by resection alone. Symptomatic recurrence and incompletely resected lesions may be treated with repeat surgery, chemotherapy, and targeted therapies. But normally where you can incompletely resect them is depending on the location of the tumor. So there are other parts of the brain that you cannot go to resect, and therefore you might just remove the tumor piecemeal as opposed to removing the entire tumor entirely. On imaging, polycystic astrocytomas are usually well demarcated, and the term cystic, you're going to see cysts with contrast enhancing muronodules. So they have a solid part and they also have some cysts. Microscopically, you're going to note the fact that they are well circumscribed with limited brain invasion. Then they have a biphasic architecture combining loose microcystic and compact dense fibrillar areas. The tumor is usually composed of bipolar cells with long, thin hair-like processes that are GFAP positive, and they form a dense fibrillary meshwork, what we call Rosenthal fibers. This usually appear as eosinophilic corkscrew-shaped inclusions, and eosinophilic granular bodies, what you call the mulberry-like inclusions. I'm going to show you an image of this. The presence of microvascular proliferation or necrosis does not imply an unfavorable prognosis when it comes to polycystic astrocytomas. So you have, this is the cerebellum. Of course, you know the cerebellum is usually different from the cerebrum. And you can see this cystic tumor, of course, with a solid part. So this is a cyst and the mural nodule. Then histologically, of course, you're going to see that this tumor is well circumscribed. You can see even parts of the cerebellum, and then you can see the cyst features. Then on high power, you can see these eosinophilic structures. These are what we call the Rosenthal fibers. And you can see what I was talking about, the these hair-like processes, well demonstrated here. You have these hair-like processes. This was to show you the cysts. Then we have your glioblastoma, which is the WHO grade 4 tumor. This is, of course, a high-grade glioma. And glioblastomas can either be primary or secondary. So a primary glioblastoma refers to new onset disease, typically in older individuals. So these most primary glioblastomas are usually IDH wild type. So you've done IDH mutations and it is not there. So that's why you talk about IDH wild type. When you find the IDH mutation, you say it is IDH mutant. So they harbor other common genetic alterations. Most commonly, they have gain of chromosome 7, they have loss of chromosome 10, they have TAT promoter mutations, and they have EGFR gene amplifications. Then we have secondary glioblastomas. These occur less frequently. They are found in younger patients, and this is due to progression of a lower grade astrocytoma. So you had like a diffuse astrocytoma, or you had an anaplastic astrocytoma that has now progressed to a glioblastoma. So secondary glioblastomas and their lower grade precursors are associated with driver mutations of IDH. So your secondary glioblastomas are usually IDH mutant. So the prognosis of individuals with IDH wild-type glioblastomas, which constitute 90% of your glioblastomas, is usually very poor. Treatment, which consists of resection followed by radiation therapy and chemotherapy. The mean length of survival after diagnosis is usually 15 months, with 25% of such patients being alive after 2 years. So you're only going to find 25% who live beyond 2 years, but majority of the patients, the mean survival is about 15 months. Survival is usually substantially shorter in older patients and in patients with lower performance status or with large unresectable lesions. For your IDH mutant glioblastomas, these are also aggressive but have a better prognosis overall, with an average survival of about 2 to 3 years. And we've said this is 10%, mainly your secondary glioblastomas. Grossly, there is a variation in the appearance of the tumor from region to region. Some areas are firm and gray-white, while others are soft and yellow due to necrosis, or red due to hemorrhage and hypervascularity. Of course, microscopically, this will be similar to anaplastic astrocytoma with additional features of necrosis with microvascular proliferation. So necrosis in glioblastoma often occurs in a serpentine pattern of tumor, hypercellularity along the edges of the necrotic regions, what we call pseudopalisading necrosis. I'm going to show you an image of this. The microvascular cell proliferation produces tufts of cells that pile up and bulge into the lumen of small blood vessels. Your vascular endothelial growth factor that is produced by the malignant astrocytes in response to hypoxia will contribute to this distinctive vascular change, that microvascular proliferation. So this is the pseudo palisading necrosis. So you have this area of necrosis that is surrounded by these cells, and then you have this is the feature of microvascular proliferation. You see this new forming blood vessels. So once you see this in a brain histology sample, then this is usually diagnostic of glioblastoma. So we've said for these astrocytomas, it's important to stratify them based on mutations of your isocitrate dehydrogenase. That is whether they are IDH1 or IDH2 mutant. And therefore from this, the tumors will either be IDH mutant or IDH wild type. So IDH mutant is associated with a considerable better prognosis than the wild type. These IDH gene mutations are recognized as key genetic prognostic markers for diffuse gliomas, and we've said that they are included in the WHO classification of brain tumors. We now have, sorry, I should have changed this. I think we have the 2022. That's the current one. 2021. So the current one is 2021 WHO classification of brain tumors. So why is it important to look for IDH gene mutations? So the normal function of IDH, these are enzymes in the TCA cycle, which catalyze the oxidative decarboxylation of isocitrate to 2-oxoglutarate. And this reaction also produces NADPH. So isocitrate dehydrogenase acts at the rate limiting step of the tricarboxylic acid. This is in your Krebs cycle. So when you have IDH mutation, this occurs, and IDH is located on the long arm of chromosome 2, and this encodes for cytosolic isocitrate dehydrogenase. So mutations affect a single amino acid residue at position 132 in most instances, and this will result in arginine being replaced with histidine, and that's why the mutation is denoted R132H, to show that at position 132, arginine has been replaced by histidine. For IDH2 mutations, IDH2 is located on the long arm of chromosome 15, and this encodes for the mitochondrial isocitrate dehydrogenase. Mutations affect a single amino acid residue, 172, which are analogs to the 132 residue in IDH1. So mutations of your IDH is seen early in gliomagenesis and is oncogenic. It confers better prognosis than gliomas without the mutations, the ones that we are calling wild type. So IDH wild type means that it is IDH negative, there's no mutation, and that means it has a poor prognosis, while IDH mutant, it means it has the mutations in the IDH, and this will confer a better prognosis. The other type of brain tumor are your oligodendrogliomas, and this is an infiltrating glioma comprised of cells that resemble oligodendrocytes. And this will represent 5 to 15% of gliomas and is the most common in the 4th and 5th decades of life. Oligodendrogliomas, they have the best prognosis among all the gliotumors. And clinically, you'll have several years of neurologic complaints, often including seizures. These oligodendrogliomas are mostly found in the cerebral hemispheres, and they have a predilection for white matter. And they are defined molecularly by looking for IDH mutation in combination with the chromosomal co-deletion of the short arm of chromosome 1 and the long arm of chromosome 19. Additional genetic alterations occur with progression to anaplastic oligodendroglioma, which will have losses in chromosome 9, the short arm of chromosome 9, which results in deletion of the CDKN2A tumor suppressor gene. So in contrast to high-grade associative tumors, you will also see EGFR gene amplifications not seen in oligodendrogliomas. We said in a glioblastoma, you're going to see EGFR gene amplification. And this is usually important to determine because there is a drug that targets the EGFR. Grossly oligodendrogliomas are usually gelatinous, gray masses, often with cysts. You can find focal hemorrhage and calcification. Microscopically, the tumors are usually composed of sheets of regular cells with spherical nuclei containing finely granular chromatin. And this is what is normally seen with the normal oligodendrocytes. But this nuclei will be surrounded by a clear halo of vacuolated cytoplasm. So it gives it a fried egg appearance, and this is what is usually characteristic of an oligodendroglioma. Typically, these tumors, they contain a delicate network of anastomosing capillaries, which resemble chicken wire. You can see calcification in as many as 90% of these tumors, ranging from microscopic foci to massive deposition. For your oligodendrogliomas, they usually can be low grade, which is usually WHO grade 1. Of course, these tumors will have reduced mitotic activity, and proliferation indices will also be low in these tumors. Or you can have an anaplastic oligodendroglioma, which is the WHO grade 3, that is characterized by high cell density, nuclear anaplasia, increased mitotic activity, and occasionally you'll see some necrosis. This may arise de novo, but more often progress from WHO grade 2. So you can have the low-grade tumors progressing to your WHO grade 3 tumors. So this is the typical appearance of your oligodendrogliomas. You can see these dark cells that are surrounded by this cleared cytoplasm, forming halos, or this fried egg appearance. You know, the way you have the yolk in the middle and then the white part surrounding it. So that's this is usually typical of your oligodendrogliomas. Then we have your ependymomas. These are tumors that arise from your ependymal cells that line your ventricular system. So they'll be found in proximity to the ependyma-lined ventricular system and the central canal of the spinal cord. Ependymomas are seen in the first 2 decades of life. They typically occur near the fourth ventricle. Sorry, my power just went off. So for ependymomas, you've said that in adults, they'll be seen mainly in the spinal cord, and more frequently, they'll be seen in patients who have neurofibromatosis type 2. Remember, initially the genetic or familial syndromes that predispose you to brain tumors, we talked about NF2. So NF2 gene mutations will give you ependymomas. So NF2 gene is found on chromosome 22 and is commonly mutated in ependymomas arising in the spinal cord, but not at other sites. Histologically, your ependymomas range from grade 1 to grade 3. So you can have myxopapillary ependymomas, which are WHO grade 1. These occur in the phylum terminale of the spinal cord. You will see cuboidal tumor cells that are arranged in a variably papillary architecture. around mucin-rich fibrovascular cause. So they are forming papillary structure, hence the name myxopapillary ependymomas. Then we have WHO grade 2 ependymomas. Most of the tumors are usually well differentiated. Of course, here you're looking for cellularity and a bit of mitotic activity, but of course, you should not see necrosis and you should not see microvascular proliferation. You can also have anaplastic ependymomas, which are WHO grade 3. Here, they'll have increased cell density, high mitotic activity. They'll have areas of palisading necrosis and or microvascular proliferation. Grossly endon MRI ependymomas are usually solid masses. Normally, they are non-infiltrative. They'll be diagnosed on histological examination. In the posterior fossa, they typically arise from the floor of the fourth ventricle, occasionally growing through the foramina of Magendie or Luschka and extending below the foramen magnum into the cervical spinal canal. Microscopically, ependymomas are composed of cells with fibrillarly processes that contain regular round to oval nuclei with granular chromatin. But you can see, we say that for brain tumors, the symptoms sometimes you can have a myxopapillary ependymoma. This is a WHO grade 1 tumor, but depending on where it is growing, like if it is going to the foramen magnum, then it's going to cause detrimental effects depending on where the tumor grows. So for ependymomas, the tumor cells form gland-like round or elongated structures, that is rosettes or canals that resemble the embryologic ependymal canal with long delicate processes extending into the lumen. You will see also what are called perivascular pseudorosettes that are often seen, in which there is a perivascular nuclear-free zone consisting of thin ependymal processes radiating towards the central blood vessel. I'm going to show you this. So these are your perivascular pseudorosettes. So you have this blood vessel, then you have this nuclear-free zone composed of fibrillary processes that are radiating around a central blood vessel. So this, when you see this microscopically, this is usually characteristic of an ependymoma. And you can see this is just to demonstrate this tumor that is growing from the fourth ventricle. When you see this, this is likely an ependymoma. Then we have choroid plexus. Of course, from your anatomy, you know that ventricles usually have choroid plexus, and this choroid plexus is what controls CSF. So for your choroid plexus, you can have papillomas or a carcinoma. And these are for your, either they are intraventricular tumors that are most often seen in children, and in whom they tend to occur in the lateral ventricle. In adults, your choroid plexus papillomas will occur more frequently in the fourth ventricle. These papillary growths recapitulate the structure of the normal choroid plexus, wherein epithelioid tumor cells cover the fibrovascular stalks. I'm going to show you this. Clinically, they usually present with hydrocephalus due to obstruction of the ventricular system by tumor or overproduction of CSF. And these choroid plexus tumors can either be benign papillomas or they can be carcinomas. And the choroid plexus carcinomas, they resemble adenocarcinomas, and these tumors are almost always found in young children. So this is your normal down here. This is your normal choroid plexus, and you can see the cells here are bright red. The lining is okay, and then all of a sudden your cells start to become atypical. So you're acquiring the loss of polarity, hyperchromasia, increased nuclear cytoplasmic ratio. But as long as there's no invasion of the basement membrane, this remains a choroid plexus papilloma. This is a choroid plexus carcinoma on the other hand, and you can see here the cells are quite large. There's increased mitotic activity. This is a mitotic activity. This is a mitotic activity. So this is, you can see the difference between a choroid plexus carcinoma and that of a papilloma. Then we say that you can have tumors that arise from neurons, or you can have a mix.